Hello and welcome everyone, and thank you all for coming tonight for the final Obesity Management webinar brought to you by obesity doctors in the ACT and the Capital Health Network. Tonight's topic is Obesity Treatment Options. The two previous webinars are on the Capital Health Network YouTube page, and this webinar will be uploaded to the YouTube page soon as well. I am Dr. Leonie Harcourt, the GP advisor at Capital Health Network. Also with me tonight are Dr. Louise Brightman, Dr. Richard Singer, Dr. Carol Huang, Dr. Deborah Inman, and Kanal from Capital Health Network. First, we would like to acknowledge the traditional custodians of the land we are meeting on. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. We also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. So all participants, so all attendees have been muted. And so if you have any questions, please type them into the Q&A section of the Zoom window rather than putting up the hand to chat. And we'll have a question and answer session at the end of the presentations. We'll also send out copies of the slides to all participants following the event. So some of you, well, hopefully all of you have received the optional pre-reading and the questions for tonight's webinars. And we'll post the results of these questions at the end of the talks as well. And tonight's event has been accredited by the RACGP for 2 hours of CPD educational activities. Please provide your RACGP number and complete the post-event evaluation survey and return them to us by the 15th of May so that we can register you for the 2 hours. If you don't do that, you're very welcome to self-record it on your dashboard. And also, if you have completed the pre-reading and answered the questions, please feel free to self-record an extra 30 minutes of reviewing performance to your CPD dashboard. So today, we're very lucky to have the Fab Four back again for one last concert. And our first presenter tonight is Dr. Louise Brightman. Louise is a psychiatrist working at the Canberra Obesity Management Service. She has a background in public health and chronic disease management and has spent the past several years working in a remote Central Australia. Louise has SCOPE certification through the World Obesity Federation. She also has postgraduate qualifications in forensic mental health, and she will be talking tonight about goal setting and management of obesity-related mental illness. So thank you, Louise.
Thanks, Leonie. Please bear with me while I just share my screen. Okay, so hopefully everyone can see that. Thank you for having me back. It's nice to be presenting again. I'll apologise in advance. These slides have a lot of information on them. I won't go through all of it, but they are there. The information's there in case people would like to look at it later on. So today I'm going to be covering goal setting and management of obesity-related mental illness. The learning objectives for this session include identifying the general treatment approaches for comorbid mental illness in obesity, discussing useful psychological strategies to manage obesity-related mental health comorbidities, and considering the risks and benefits of using psychotropic medications in people with obesity. Just briefly, an overview. We'll be doing a quick summary from the first session. Then we're going to be discussing how to prioritise, or when it's appropriate to prioritise mental illness over weight loss, and then looking at the general goal setting principles in weight management, and having a look at the psychosocial capacity and the which is sort of a prerequisite for engaging with obesity management service, but it's also important for people working in primary health care in terms of assessing patient suitability to engage in any weight management program. And then we'll just briefly touch on some psychological strategies and some psychotropic medication use. So just to summarise, obesity and mental health, it's a complex interplay. There are lots of factors that can that feed into one and the other. and they involve things like HPA axis dysfunction, metabolic derangement, inflammation, mood dysregulation, as well as a range of genetic, environmental and iatrogenic causes, particularly medications. So there's a direct relationship between the severity of mental illness and the higher the BMI, and also the increased number of medical comorbidities and an increased risk of mortality. Some of the common obesity-related mental health conditions that I'm sure many of you have already seen and managed include mood and anxiety disorders, eating disorders, substance use disorders, and psychotic illnesses. So just taking a step back and having a think, it's always important to remember that obesity itself is not a mental illness, and that not everyone with obesity will have a comorbid mental illness. So thinking back to the first session I did, we talked about the prevalence of some mental illness in obesity. And so we know that with mood disorders, it can be as high as 30 to 35%. Anxiety, binge eating disorder, there's a range sort of anywhere between 5% up to 20 or 30% in some cases. But there's a lot of people with obesity that, from a mental health perspective, are actually functioning quite well. So it's really important before we consider any sort of weight loss strategies or engaging people in discussion about mental health to assess their psychosocial capacity, but also their underlying mental health. So it's important to clarify if there is any underlying depression or anxiety or psychosis, and in particular, substance use and binge eating disorder. So those are two that are often hard to detect, because a lot of the time people don't help seek for those types of disorders. If someone has an acute mental health presentation, so they're acutely psychotic or really in the depths of despair with a depression, it's really important that we prioritise the management of those things first before thinking or encouraging any weight loss strategies. But that's not to say that we can't at the same time encourage people to just try and adopt a healthy lifestyle for their overall health and well-being. A lot of people think that if someone has a psychotic illness, then they wouldn't be suitable for the obesity management service, or that they're not suitable to have discussions about weight management and weight loss, but that's not always the case. So again, I'm sure I know a lot of GPs in town are doing a really good job at managing patients with a chronic schizophrenia, where they might have ongoing chronic symptoms of auditory hallucinations or amotivation, those sorts of things. But it's interesting to see that some of those patients do actually have the capacity to make some positive lifestyle changes, and we want to support that as much as we can. So as I mentioned before, an untreated binge eating disorder or a substance use disorder really poses a clinical dilemma for us, because if we're pushing to help with weight loss, it can actually be counterproductive. So if we think about a binge eating disorder, if that's not diagnosed or treated, it's going to be very hard for anyone to make any sort of sustained lifestyle and dietary changes. And there's also the risk too that if someone stops engaging in binge eating activity, depending on the underlying causes of that binge eating activity, it might actually lead to them turning to alcohol as another way to self-soothe, or as we saw recently at OMS, we had a patient who has taken it upon themselves to restrict restrict their binging, but then they've resorted to a form of self-harm by picking and scratching themselves. So we don't want to do that. We want to try and help with the binge eating disorder before we start doing recommend any restrictive behaviours with their diet. Keeping in mind too that there's often a trauma background, and that might need to be addressed separately to the therapy that someone receives for binge eating disorder. Even when someone with a binge eating disorder or substance use disorder has received treatment, we've got to be really careful that we don't then push them too much and that their focus switches to going into any sort of really restrictive dieting. So there are cases where some people might have a binge eating disorder, and they've received treatment, and then the pressure of trying to lose weight increases their stress and they start binge eating again, or they might even develop a different type of eating disorder. So one where they might restrict, or where they might binge and then use compensatory mechanisms like bulimia nervosa. So in terms of just some general goal setting principles, we have to make sure that the goals are realistic. Often people will come in and have a goal weight, or say, look, I want to get below 100 kilograms and I want to do it before Christmas or before a wedding. So just highlighting to the patient that it's not so much about a specific goal weight, and that really the focus should be on preventing further weight gain in the first instance. And sometimes people can be disappointed by that, but I think it's really important to highlight that if someone can maintain their weight within maybe 3%, because there will always be some fluctuations, but if they can prevent that further weight gain, that's actually, they're already doing a good job. If we are going to be looking at what sort of weight can be helpful in terms of being clinically relevant, we do like to aim for 5% of the total body weight loss. Managing expectations is really important, particularly in regards to weight loss plateau. So someone can do extremely well with lifestyle interventions or with more intensive things like medication and surgery, but there will come a time where that weight loss will plateau. And often that won't, if someone's had a goal weight in mind and they plateau prior to that, it can be really demoralizing for them, and it's not meeting their expectations. There's also the risk of weight regain. So explaining to patients that it's a constant battle to keep the weight off. Again, even if they've done a really good job losing the weight, there's going to be that tendency over time for it to come back on. And it doesn't mean that they've failed. It means they're sort of fighting those range of factors that I mentioned before in terms of environment, genetics, those things. It's also important to let people know that, or be aware that not everyone is suitable for intensive interventions, and it might just be that lifestyle options are the best for some people, and that can be for a range of reasons. It might be that there are social barriers in terms of finances, or ability to attend appointments, buy certain foods or certain supplements, or the fact that they don't have the psychological capacity to engage in those more intensive interventions. So this is a study that the OMS did a few years ago, looking at attendance rates, so engagement rates, and also weight loss. And it was comparing the patient cohort, those without a mental illness and those with a mental illness. So there was a total of the 162 patients, 37% had a diagnosed or existing mental illness. And what was interesting is that the attendance and engagement rates were similar for both groups. And if we have a look at this next slide here, you can see the graph on the left shows the percentage weight change for people without mental illness, and then the graph on the right shows the percentage weight change for people with mental illness. So you can see that it is actually a similar shape in terms of the graph, in terms of weight loss, weight gain, weight stability. So this can demonstrate that although the weight loss wasn't, the amount of weight loss wasn't as much in the group with mental illness, it's a similar pattern and shows that they can still engage and get some benefits from being with our service. It's also important to note on this slide here, if you look at the people without the mental illness, and some people have achieved more than 15% weight loss, there were far more people doing more intensive interventions compared to the ones with weight loss, compared to the ones with mental illness. So really, if you look at the graph on the right, the majority of those patients were doing a really good job just with lifestyle factors alone and a little bit of medication. So psychological strategies are really important if people have a comorbid mental illness. The type and the severity of the mental disorder are really going to dictate which psychological therapy is suitable for them. There's a strong evidence base for cognitive behavioural therapy for people with depression, anxiety, and binge eating disorder. And again, I think GPs are probably very familiar with writing up GP mental health care plans and then referring on for some sort of CBT for their patients. Other useful psychological strategies for mental illness in obesity include interpersonal therapy, some dialectical behavioural therapy. Guided self-help is becoming quite a big, it's gaining a bit of evidence base, and I think that's because everyone's using devices and they sort of taking ownership of their therapy, I suppose. So that's really emerging as a potential option for a lot of people. At the OMS, we've got an informed eating group. It used to be called emotional eating, but a lot of the patients didn't feel that really related to their particular circumstance. So it's not just about emotional eating or comfort eating, but it's about people recognising why they might be eating. Are they upset, angry, happy, distressed? Is it more to comfort them? And teaching people how to better listen to their own hunger cues and fullness cues as well. Here in Canberra, there's also the body image group at ANU, and our OMS psychologist has made a few referrals there for some ongoing support regarding body image issues. Motivational interviewing is also a really good technique, particularly if someone is not at the appropriate stage of change to engage in some weight loss programs. So that can be really useful for people who are not quite ready, or they're not sure if they want to embark on that journey, and also particularly for people with maybe a substance use disorder. So as I'm sure everyone's aware, cost and access issues are an ongoing concern in terms of people being able to access suitable psychological therapy. As I mentioned before, GP mental health care plans are really important. There's now the MBS eating disorder plan, which can actually provide up to 40 weeks or 40 sessions of therapy for someone with a binge eating disorder. But the criteria for that is quite strict. But I think that's a really good resource that we should be trying to use more often if we can. Eating disorder programs and clinics also have a really important role. There's an eating disorders program here in Canberra, and there are also a range of private clinics, and some of them are doing a really great job, and they offer one-on-one CBT-based therapies for people with binge eating disorders and also other body image issues as well. So organisations like Body Matters, that's a really good option for some people if the wait lists for the public sector are too long. And those sorts of organisations also can offer a rebate as well if there's a mental health care plan or an eating disorders plan. So I think it's safe to say that we all know that there are risks of weight gain with a lot of the psychotropic medications. And ideally, if we could, we would always choose the safest medication, or the medication that's going to cause the least amount of weight gain. But that's not always possible. And it really depends on the severity of the mental illness, historical relapses, and what their prognosis is going to be. So if we think about that, a patient with chronic schizophrenia or a treatment-resistant schizophrenia, if they're on clozapine, then they've already failed at least 2 other trials of an antipsychotic. So the options are kind of going to be limited as to whether or not we can sort of go in there heavy-handedly and say, okay, let's cut the clozapine out or let's reduce it. It just might not be possible. So then we have to think, well, how can we help them in other ways? So there's always a risk-benefit analysis that needs to happen in terms of weight gain, sedation versus insomnia, the impact on metabolic factors. But I think the key message is it's really difficult to manage obesity or to encourage some healthy lifestyle changes and weight loss if there is an untreated mental illness. So I think that's probably the key take-home message from my talk. And I just thought I'd quickly talk about some medications. Again, this is something people probably already know, but if you are starting off someone on a new medication or it's a new diagnosis, it's always good to consider an SSRI or an SNRI before moving on to the tricyclics or the monoamine oxidase inhibitors. As I mentioned in the first talk, mirtazapine is a really good antidepressant, and it does have some good anxiolytic effects, but mostly I see it used off-label for sleep. And again, that can be beneficial, but it does lead to increased sedation and increased appetite, particularly for carbohydrate foods and foods that contain a mix of dairy and sugar, interestingly. So biscuits, cream, ice cream. So the other thing to think about with mirtazapine is that if you are going to use it in an off-label manner for sleep, it's the lower doses that are actually more effective as opposed to the higher doses. So at the lower doses, it's really targeting the histaminic receptors, which can help increase the duration of sleep and can also make people more sedated. But at the higher levels, it's the noradrenergic activity actually takes effect and you lose those sleep benefits. So really, if you're prescribing 30 milligrams of mirtazapine, the patient's probably not going to get a lot of sleep benefit from that. So that's something to keep in mind. If you did want to try a lower dose of the mirtazapine, it's also good to keep in mind that if they are at 30, it might be that a depression is being treated as well. So you need to make sure that they're not going to relapse in the context of a suboptimal or a subtherapeutic dose. With antipsychotics, it's a bit of a, again, risk-benefit analysis. So the first generation antipsychotics are less likely to cause weight gain, but they have their own problems in terms of extrapyramidal side effects. There are a few second generation antipsychotics that are becoming more popular and there's a growing evidence base. So aripiprazole, brexiprazole, they don't tend to cause weight, which is good. But again, if someone has a really severe chronic psychotic illness, it might be that that single agent alone isn't going to hold them. With mood stabilizers, the majority of them are weight promoting, but again, sometimes they need to be prescribed if there is a treatment resistant depression or a bipolar illness. If we think about medications for binge eating disorder, we know that there's some evidence for high dose SSRIs, including fluoxetine at 60 milligrams. And lisdexamfetamine has actually been approved for binge eating disorder. But interestingly, it's not approved for concurrent weight loss, and there hasn't been a lot of evidence to show that it has that dual benefit. So really, that would be focusing just on the eating disorder. It wouldn't be used for treating any obesity or facilitating weight loss. There are some benefits to using some off-label medications. So topiramate can be used, it's an anticonvulsant, but it can be used as a mood stabilizer and for migraine treatment. And it has the dual effect of also being classed as an anti-obesity medication. So that's something to think about if someone is presenting with a migraine or a bipolar illness. And prazosin, there's evidence for that to treat PTSD-related nightmares. So if someone also has some hypertension, it might be that you'll get a dual benefit of that and you can reduce some of their other medications. That's just a little table sort of outlining just some common alternatives, if anyone's interested. And this is my final slide. So just something to consider in the post-bariatric space, that the pharmacokinetics are changed following bariatric surgery. So it depends on the type of surgery, but there are some similarities in terms of how the pharmacokinetics change. So for example, the gastric emptying rate can change. So if someone's on an XR formulation of a medication, so for instance, venlafaxine and SNRI, we need to think about, can we change that to an immediate release, or do we actually need to change medications? Because if the gastric emptying rate increases, there's not enough time for the patient to absorb that medication, which means they could experience discontinuation or withdrawal symptoms, or they could actually develop a relapse over weeks to months. So that's just something to think about. And those things can also happen in terms of if people lose weight, then there's reduced adiposity, which can impact on the lipid-soluble medications. And also, when people lose weight, often their liver and renal function will improve. So then that means that the metabolism and excretion of their medications is going to change. And it might be that they need higher doses for some things. But yeah, I guess the takeaway point is, particularly for the antidepressants, we've got to be mindful of that after people have had bariatric surgery. And that's all I have, but I'm happy for anyone to email me if they have any questions or would like to discuss anything further. Hopefully everyone could hear me and it was okay.
Yeah, that was great. Thank you, Louise. Questions have started popping up, and I've got some questions myself, but we'll save them for once everyone's has spoken tonight. So we'll just move on to our second speaker. So our second speaker tonight is Dr. Richard Singer. He is a renal physician at the Canberra Hospital Renal Unit and also in private practice at RSCM. His main interest is in kidney disease and nutrition, with a focus on the impact of nutritional deficiencies and excess body weight on health. Richard also has SCOPE certification, and he's the medical lead at the Canberra Hospital for the Renal Weight Management Program and the Canberra Hospital Chronic Kidney Disease and Home Dialysis Programs. Richard tonight will be talking about treatments for obesity, including orlistat, phentermine, and topiramate. Thanks, Richard.
Thank you for those kind words, Leonie, and thank you to CHN for inviting me to talk. Let me see how I go sharing my screen. Okay, I think that should be sharing. Okay.
Yeah, we can see that.
All right, so the learning objectives for this part of the webinar are to do with orlistat, phentermine, and topiramate. So I'm hoping that you will learn a bit more about when to use, when not to use, and also something about how to consider using them for weight management. Before I get on to the drugs themselves too much, I just wanted a couple of slides with a little bit of revision, because some people won't have come to the last couple of webinars, and others will be a bit like me and they'll have come but then forgotten various things that they were hoping to keep in their mind. So orlistat is the only drug I'll be talking about that doesn't work by suppressing hunger. And really it's only orlistat and the SGLT2 inhibitors, which I won't be talking about, where you get weight loss without a hunger suppression. And that hunger suppression is for a given body weight, which I come on to a little bit to reiterate in the next slide. And if somebody actually has ongoing weight gain, so that's not weight regain, but primary ongoing weight gain, that's often not going to be driven by hunger. It usually has other factors to do with their lifestyle, which may be non-hungry eating from various emotions. It may be binge eating, it could be medications, and some of the factors that Louise spoke about before. And before you consider using an appetite suppressant, you need to address those factors. So by suppressing hunger at a given body weight, I'm talking about set points, which was one of the topics of my last presentation. And so if you imagine a patient who weighs 100 kilograms and they use lifestyle, diet mainly, to get down to a weight of 95 kilograms, and then they plateau at 95, unless they further restrict their diet, they won't continue losing weight. And at that lower weight, they will usually feel hungry most of the time. Whereas if you use a medication to get somebody's weight from 100 kilograms to 95 by suppressing hunger, once again, they won't continue losing weight below their plateau, which in this case is 95 kilograms. But the difference is that they usually won't feel as hungry, or sometimes hungry at all, when they're at that lower body weight. But if they drop their weight further through diet, say to 90 kilos, then they would start feeling hungry. And then if you take the third situation where somebody also weighs 100 kilos, but they're gaining a kilogram a month, and they come along and get a medication for appetite suppression, they'll probably still lose a little bit of weight in the short term, but they weren't eating because of hunger in the first place. Some of the eating will be due to hunger, but a lot may not be. And so after a year or a few months, their weight will probably be above baseline. So that's a treatment failure, and that's not what we want to see. So the general indications for a weight loss medication are having a body mass index over 27 with a weight-related complication. And in my next slide, I show you an example of that, or having a body mass index of 30 or more with or without a weight-related complication. And every study that's been done with a weight loss medication has been in conjunction with calorie restriction and increased physical activity. And it's worth bearing that in mind. And it is certainly recommended that they be used in conjunction with those two things. The fourth one isn't in the TGA prescribing guide, but I think it is essential to consider before you start. And that's the patient's financial capacity, because if the medication works, it's only going to work while they're taking it, and they're going to be taking it for years. So if they don't have the financial capacity for using that medication, you may be better not to start it in most situations. So body mass index is a fairly crude measure of adiposity, and you can have two people with the same body mass index and vastly different amounts of fat, particularly visceral fat. So this graph that I've got on the right, the red line is showing an albumin-creatinine ratio, and the green line is the body mass index. And I'd been treating this lady for quite a few years for a chronic glomerulonephritis, which I thought I'd got into remission, and she had a nice low albumin-creatinine ratio. Then she got pregnant and gained weight through the pregnancy and kept the weight on. And after pregnancy still had quite a high albumin-creatinine ratio. So we weren't sure whether this was the glomerulonephritis coming back a bit or the weight. But we started her back then on Ozempic, and she lost a relatively small amount of weight initially, but that small amount of weight loss was enough to dramatically lower the albumin-creatinine ratio. And it did lower a little bit more as the weight loss continued, but you got most of the benefit from the first few kilograms. And it's worth keeping that in mind. So if a drug doesn't seem very good because you only get 5% weight loss, that 5% weight loss can be very clinically significant for many patients. And just because someone's body mass index is just under 30, it doesn't mean that they won't derive some significant benefit from a medication. So orlistat is one of the weight loss medications that's actually licensed by the TGA. There are a few now, but it's the only one licensed for long-term use that I'll be discussing today. And I think most people probably know how it works. So it inhibits gastric lipase. It's a 3 times a day medication. So immediately that produces adherence issues in the long run. It doesn't work with a low-fat diet, and it doesn't work with a high-fat diet. So with a low-fat diet, it doesn't work because it works by preventing fat absorption. So if you're not eating much fat, you don't get much or any benefit. And it doesn't work with a high-fat diet because you get unacceptable side effects with oily flatus, diarrhea, and abdominal discomfort. But it's been around for a long time, and it's considered safe for long-term use. It does have data showing that it improves surrogate endpoints, such as HbA1c, cholesterol, blood pressure, maybe is associated with less new diagnoses of mild chronic kidney disease, and maybe some cardiovascular benefits, although those aren't from RCTs. The mean weight loss is only about 5% above placebo, and the cost is, I would say, moderate to high, depending on your view of that, around about $100 a month for the full dose treatment. Aside from the side effects of GI upset, you are also, the patient is also at risk of some vitamin deficiencies. And in post-marketing data, there is quite a significantly higher risk of acute kidney injury. The cause of this is not entirely clear, but it's quite probably related, I think, to oxalate stones. So there's been many case reports showing oxalate stones onset after starting orlistat. And that makes sense because any cause of fat malabsorption results in greater absorption of oxalate from the diet. And of course, the only place it can go is the kidney, and the kidney can't get rid of all that much before you get a stone. So phentermine is licensed for weight loss in Australia as well, but it's only licensed for less than 3 months use, which makes it completely useless if you're considering the TGA guidelines. Because once you've had success with the weight loss medication, if you stop it, they're going to regain weight. Nevertheless, it does have TGA approval and a dose up to 40 milligrams a day. It lasts for the whole day. It has a long half-life. It's mostly got renal excretion. And even at the lowest dose, 15 milligrams, it is effective. So about 4% weight loss compared to placebo. Now that is below the usual cutoff of 5% for clinically significant, but could still be helpful. It's actually relatively expensive if you prescribe it as the branded tablets. But when you prescribe it as a compounded medication, it often works out cheaper, depending on the pharmacy, obviously, as long as you prescribe 100 capsules at a time. Generally, the compounding pharmacies make up 100 capsules at a time. So if you prescribe in that quantity, you get the cheapest cost per capsule. And $40 a month is reasonably affordable. But phentermine does have quite a few issues, and I struggle to use it on very many of my patients. So one issue is drug interactions. So you can't use it with, or you can't safely use it with just about every antidepressant. So certainly the SNRIs are a problem because of the noradrenaline reuptake inhibition. MAOIs are a problem. Tricyclics are a problem. And SSRIs pose a risk of serotonin syndrome. So that limits the number of people with significant obesity you can give it to. And then in my world, where everyone has hypertension, that is also a problem. Now, having said that, if you lose weight with the medication, your blood pressure may well overall improve. And there is some data to show that you do get blood pressure improvement with phentermine if there's weight loss. There are also quite a few more sort of mental side effects in terms of the insomnia and anxiety. And a big issue, as I said before, is the short-term licensing. I'm going to come back to phentermine in a minute in terms of using it in combination with topiramate. So topiramate's been around for ages. I think it started as they were trying to use it as a diabetic drug, and then it turned into an anti-seizure drug. Now it's used for migraines and weight loss as well. It's not licensed by the TGA for weight loss. It is licensed in America in combination with phentermine for weight loss. And there's pretty good data that it's effective in monotherapy. So you get a weight loss of between 5 to 8% with topiramate alone, depending on the dose. Like phentermine, it has a predominantly renal excretion, so you'd have to look at lowering the dose in people with reduced renal function. And one of the more feared side effects, at least in America, is the teratogenicity. Now, none of these, except perhaps orlistat, would be considered safe to use in pregnancy, but for topiramate, there is a clear teratogenic effect. So adequate birth control for women that may become pregnant is important. It increases the risk of calcium-containing kidney stones and causes a metabolic acidosis in about 30% of people who take it. And those two things are related. You also get taste disturbance, and there's a very rare side effect, so 1 in several thousand, of a pseudo-closed angle glaucoma, which is an idiosyncratic reaction, swelling of the choroid and then an acute glaucoma, not related at all to the more common open angle glaucoma. So the combination is better studied and is called Qsymia in America, where it's licensed. So the topiramate that we have, if it's non-compounded, is immediate release, and the phentermine that we have is slow release. So you can see that it's the opposite for this Qsymia. Immediate release phentermine, slow release topiramate. The idea being that you take a tablet in the morning, you get a hit of phentermine, so you're not worried about the insomnia, and then you get knocked with the topiramate, so you fall asleep. But unfortunately, it didn't really work like that. They were hoping with the combination that they would lower the number of the proportion of people with adverse effects, but it didn't work. You tended to get additive effects. So you still get around about 15 to 20% of psychiatric type side effects and cognitive side effects with the combination. And ultimately, about 18% of people taking Qsymia need to stop due to an adverse effect compared to 9% placebo. That's substantially higher than for other agents such as GLP-1 agonists. There is a 4-fold higher risk of kidney stones. Now, that's only 1.2%, but you have to remember that the studies only go for a couple of years. And so given that, the rate of kidney stones in adults now is about 20 to 30% over the lifetime, a 4-fold higher risk is probably quite significant with long-term use. Now, you can request this as a compounded medication, but you won't be able to get, as far as I'm aware anyway, quite the same pharmacokinetics as the Qsymia, because without having 2 capsules. So you can either have both slow release, which is probably not ideal for the phentermine, or both immediate release. So there's probably not a lot of advantage going with slow release for it. The cost is similar to the compounded phentermine, as long as you're prescribing the 100 capsules at a time. And you do gradually increase the dose. So you would start at, if you were following Qsymia, you'd start at 3.75 of phentermine and 23 of topiramate. And you can increase every couple of weeks. I personally don't increase faster than every month because I have had so many problems with the cognitive and psychiatric side effects with it. And I try to go slower to get more tolerability. The maximum dose is 15 phentermine and 92 of topiramate. And given that the Qsymia has some long-term data using it at that dose, I personally feel comfortable with long-term phentermine at 15 milligrams as well, notwithstanding the TGA advice. So I've talked about orlistat, which doesn't work on hunger. It works on fat malabsorption, topiramate and phentermine, which do work on hunger. And these drugs all have their pros and cons. The orlistat is relatively ineffective. It is somewhat expensive, I think, and I think adherence in the long run is a problem. And it doesn't address hunger. The phentermine and the topiramate are both fairly cheap, particularly topiramate, without needing to go to compounding it. But the psychiatric and cognitive side effects are a problem for many patients and make it difficult to use them. So the main advantage for me when I'm using them is the cost in terms of which you may try first, compared to a GLP-1 or Contrave. Thank you. Stop sharing. Yeah.
Thank you very much, Richard. That was also very interesting. And more questions have appeared. So I'll move on to our third presenter now. So that's Dr. Carol Huang. Carol is a respiratory, sleep medicine and general internal medicine physician and works as the Director of Respiratory and Sleep Medicine at the Canberra Hospital and privately at RSCM, where she consults on sleep and obesity medicine. Her main interest is medical obesity management and non-invasive ventilation and pulmonary physiology. Carol too has SCOPE certification, and tonight she'll be talking about the pharmacotherapy for weight management, specifically naltrexone, bupropion, liraglutide, semaglutide, and new medical treatments on the horizon. Thank you, Carol.
Thank you, Leonie, and thank you to Capital Health Network for inviting me to speak tonight. And let me share my screen.
We've got it, Carol.
Is it working?
Yep, it's working.
Yeah. Okay. All right. So, so for tonight's talk, I've only got 2 learning objectives. So hopefully by the end of the talk, you will be able to describe the likely outcome and adverse effects of using agents such as naltrexone, bupropion, and the liraglutide, and then also be able to outline recent research advances in anti-obesity medications and be aware of what's actually on the horizon. Now, we've had a long history of trying to develop a variety of medications aiming at treating our weight problems. And as you can see, back in 1933, they were the first medication that's been developed for obesity. And phentermine's actually been around since 1959. Orlistat came much later in 1999, and in 2012, phentermine topiramate came onto the market. So today I'm going to talk about the more recent sort of developments. So we're going to spend some time talking about the naltrexone, bupropion, and also the liraglutide, which are currently available on the market. Then we might actually also look at some data about semaglutide, and then also talk about what might be on the horizon in the next few years. So this is actually quite an exciting time to be treating obesity. Okay. So naltrexone, bupropion is also known as Contrave, and many of you will know that bupropion is an antidepressant, and it's being used to assist patients to stop smoking. And naltrexone is used to actually help with alcohol addiction. So in combination, the drug is actually marketed as an anti-obesity drug, and this is on the basis of the Contrave obesity trials. And there are actually 3 main RCTs, and they all administered 8 milligrams of naltrexone and 90 milligrams of bupropion tablets. And you build up the dosage slowly until you eventually arrive at 2 tablets twice a day, and they compare this with placebo. In these trials, the main participant age is in the mid-40s, and as with most of the obesity trials, the vast majority of the subjects are female, and in these particular trials, they all had controlled comorbidities. So in the first core trials, they had 3 arms, with a third arm that actually had a lower dose with lower weight loss. And then subsequently, the core 2 trials, they just compared the full dose with the placebo, and they were able to show 6.4% weight loss in the interventional group, compared with 1.2% with the placebo at 56 weeks. And this is on this basis that Contrave became FDA approved and has been marketed around the world for weight management. And Contrave has a number of side effects. It can cause GI symptoms such as nausea, dry mouth, constipation, diarrhea, and vomiting. And it can also have issues with headaches and dizziness, and insomnia and sleep disorders have also been reported. Then the next player that came to the market is liraglutide or Saxenda. And I very much remember when Saxenda became approved and came to the market, I think on Christmas Eve in 2015, when I first started my journey as an obesity physician. And Saxenda was actually, the trials were based on SCALE program, which is a series of 4 randomized controlled trials, and they compared the placebo versus 3 milligrams of liraglutide daily over a 56-week period, except for one of the trials, which is called the SCALE Obesity and Prediabetes Extension Trial, which actually spanned over 160 weeks. So this is one of the few medications on the market that actually has, long-term trials. Again, most of the adults are in their 40s, and the majority being female, with a BMI range of somewhere between 37 to 39. And in all of these trials, they started with lifestyle modification, including at least 150 minutes per week of physical activity, and also reduced daily energy intake by about 500 calories below the individualized energy requirements. And the reported weight loss was 8% at 56 weeks versus 2.6% with placebo. And at 160 weeks, the reported weight loss is 6.1% compared to baseline, versus 1.9% in placebo. So there's actually a small weight regain after the first year of treatment. Oh, sorry, wrong slide. Now, when you actually look at these trials, I think it's actually important to have a look at what the dropout rate looks like. And in the liraglutide, the dropout rate is 8 to 10%. And it sort of seemed reasonably high to me. But then when you look at a placebo arm, the dropout rate in the placebo arm is actually twice that of the treatment arm, which is quite interesting. And the dropout rate in the extension study is actually 65%. So again, they have a number of side effects, including somewhat increased heart rate. So this usually sort of translated to an increased heart rate of 2 or 3 beats per minute, which for most people isn't a problem. But if you have patients who already have tachyarrhythmias, this might become an issue. It's very common to have GI side effects with constipation, diarrhea, nausea, dyspepsia, decreased appetite, and vomiting. And these symptoms can be minimized if you actually titrate your medication slower to tolerance. And there are some reports of upper respiratory tract infection or nasopharyngitis and influenza. Hypoglycemia can be an issue because liraglutide reduces insulin resistance, and it is first marketed as an anti-diabetes medication. So if you have a patient who has diabetes, particularly if they take insulin, then I think monitoring blood sugar might be quite important. And finally, as with many patients who are actually losing weight, it's not uncommon to complain of dizziness and headaches. So I have a summary slide which is taken from this paper in the World Journal of Men's Health. I have no idea why they're publishing this in the Journal of Men's Health when the majority of the participants are female. But anyhow, so these are the results from meta-analysis. And as you can see that it lists a number of studies of more than 1 year duration. There's actually plenty of studies for orlistat, and but only a handful of studies with phentermine, topiramate, naltrexone, bupropion, and also liraglutide. But the number of patients in these for these medications are actually quite substantial. And I just wanted to show you a comparative weight loss of drug versus placebo. And you can see the orlistat has an average weight loss of 4.6%, and phentermine, topiramate a little bit more, 8.5%, naltrexone and bupropion at 6.1%, and the liraglutide at 7.1% at 1 year. Now, the other important thing to actually have a think about is if we were comparing with not using medication, what are actually the odds ratio of being able to achieve clinically significant weight loss? And as you can see here, with all medications, it does significantly increase your likelihood of being able to lose more than 5%. Phentermine, topiramate is probably most effective in this category, and it increases your odds by about 9 times, and liraglutide about 5.5 times. But even with the use of anti-obesity medications, we have to remember not everyone responds, and the percentage of patients who have lost more than 5% at 1 year ranges somewhere between 48 and 72%. So about 40% of patients on liraglutide will actually not achieve a clinically significant weight loss that persists for 12 months, and a substantially lower percentage of patients will achieve more than 10% weight loss. Okay, so what's now on the horizon? So I think you would have seen lots of media reports about Wegovy or semaglutide. This is actually exactly the same medication as Ozempic, but Novo Nordisk has decided to to market it for obesity under the trade name of Wegovy. And this is actually done on the basis of the STEP trials, which used a 2.4 milligram weekly over a period of 68 weeks. This is now FDA approved and available in the USA. It is actually also TGA approved, but there is no, the drug is not yet available in Australia. So this is marketed on the basis of the STEP trials, and all the participants have at least one weight-related comorbidity, in addition to being overweight or have obesity. The mean BMI in these trials are reasonably high, 37 to 38 kilogram per meter square. And all of the patients received a lifestyle intervention every 4 weeks with a reduced calorie diet of 500 calorie deficit, as well as a physical activity of 150 minutes per week. So the STEP 1 trial reported a weight reduction of 14.8%, and this is versus a placebo group reporting 2.4% weight reduction, but they did not actually report the dropout rate. And then a number of parallel studies were done, and then they have pulled data from step 1 to step 3, and this showed these 3 trials, when pulled together, showed a total body weight loss of 12% in addition to placebo. So never before have we had any anti-obesity medications that actually showed an average body weight loss of more than 10%. So this was, quite impressive at the time when the study was released. Now, they also subsequently did a longer-term trial, a maintenance trial, where everyone was given semaglutide for 20 weeks. And in this particular trial, after 20 weeks, the average weight loss is around 10.6%. Then they randomized the patients to semaglutide or placebo. And unfortunately, when you stop the medication at that stage and went on to placebo, there is a 6.8% weight gain compared to those who continued on semaglutide, where they continue to lose another 7.9% of weight, and the dropout rate in the study is 0.8%. Now, the side effect profile is in fact quite similar to liraglutide, and the contraindications are exactly the same. So at the time when this paper was published, it sort of received quite a lot of negative press, and people sort of say, "Oh, look, if you're on it, you got to be on it forever." But in fact, this is not, treating obesity is no different as treating any other chronic disease. When you treat blood pressure to go, or you treat diabetes with HbA1c to go, when you reach the goal, you don't usually tell your patient to stop medications, and this is no different. So these graphs just shows what actually happens when you stop the medication. So if you switch to the placebo, then waist circumference starts to continue to will increase, and whereas if we continue with the medication, then the waist circumference continues to go down, as does the weight. The other thing that's actually quite interesting to me is this trial ran for 68 weeks, but it is actually quite possible that we haven't actually reached the maximum effect even at 68 weeks. So that's something to think about. Whereas with other medications like liraglutide, when you treat with liraglutide on the right-hand side, you find that most of the weight loss effect actually is achieved within the first 6 months or so. So it seems that semaglutide tends to can allow people to lose weight over a longer period. Now, this is a phenomena of stopping the medication and then having weight regain new. In fact, we knew this for a long time ago. When they did the liraglutide trial, you can actually see they did the liraglutide did exactly the same. So if you start off with liraglutide and then you stop the medication at 20 and week 0, and then give the patients a placebo, weight regain occurs immediately. Whereas if you continue to give the medication, then you'll see further weight loss. Now, sometimes when patients come to see us, the doctors, there is sort of an urge to immediately implement sort of anti-obesity medications. But I just wanted to point out to you or the sort of some of the data from the liraglutide study. So in this particular study, what they did is they have about 5-6 arms where patients received a variety of different medications, including placebo in gray, and different doses of liraglutide all the way to 3 milligrams. So as you can see, if you the patients who received the placebo clearly did not lose weight as much as those who received the medications, and we know that there's nothing new here. But at week 52, all of the patients that are on placebo were then switched to liraglutide 2.4 milligrams, and then they followed these patients and eventually put them all on 3 milligrams. And what they then did is they followed these patients, but at the 2-year mark, actually the patients who were initially on placebo and started the medication late achieved the same weight loss as those who started on the medication from the word doctor. So what this sort of tells us is it's okay to start with lifestyle intervention, pursue that for a period, and if you find that you need to, you can add the medications, and the ultimate outcome is not going to be that different, and you're not potentially disadvantaging your patient. And I think that's important to know. Okay. Now, I want to spend a couple of minutes just talking about the STEP 8 trial, which is actually published, early last year. So the STEP 8 trial is a little bit different. This is probably one of the very few head-to-head trials where you're comparing one anti-obesity medication to another one. So in this particular study, they recruited 338 patients, 126 were randomized to receive a semaglutide, 127 liraglutide, and 85 on placebo. And what they have found at week 68 is liraglutide group lost an average amount of about 6.4%, whereas the semaglutide group lost 15.8% in body weight. And those who had a lifestyle intervention along and received the placebo lost 1.9%. And you can actually see that the curves start to separate relatively early, and then the group receiving semaglutide 2.4 per week loses more weight compared to liraglutide 3 milligrams per day throughout the entire 68 weeks. So semaglutide seems to be more efficacious compared to liraglutide in a head-to-head trial. Okay, now I want to spend my last few minutes talking about what's on the horizon, and this is actually quite an exciting development. So there are now agents that are dual receptor agonists. So this is an example of a tirzepatide, which is a GIP receptor and GLP receptor agonist. So it's actually the same. It's actually the same one compound that can actually bind to the GLP receptor, which is in the beige here on the left. But they also can bind to the GIP receptor, which is in the dark blue. It is a 39 amino acid modified peptide, and it selectively binds to and activates both GIP and GLP-1 receptors. And that's how the medication works. And this is the first study that's actually been published for tirzepatide. Well, actually, these are the series of trials, with the first one being SURMOUNT-1 that was published last year. And I gathered the SURMOUNT-2, which is obesity management with type 2 diabetes. They have, the drug company has released preliminary data, and I gather that the full data will be released at the ADA meeting this week, I think, this week or next week. So anyway, May 2023, and there's a couple more sort of trials where we can expect some sort of results in association with intensive lifestyle intervention and also weight maintenance trial. So this is coming very soon. So let's look at some of the information here. So this is SURMOUNT trial was actually published in the New England Journal of Medicine in last year. And for the first time, we start to have medications that are almost as efficacious as bariatric surgery. So they, in the SURMOUNT-1 trial, they had they used the tirzepatide in 3 different doses and compare that with placebo. And you can see even with the tirzepatide at the lower dose, which is a 5 milligram per week, you are looking at a weight reduction of about 15% from baseline. And the effect can be as much as 21% from baseline if you use tirzepatide 15 milligrams. And with the placebo, you're looking at a 3.1% weight reduction. And so this is impressive data showing the efficacy of tirzepatide. Now, it's hard for me to actually sort of look at how to interpret the data for adverse events, because if you actually look at reporting of at least more than one adverse events, there's an 80%, of the participants all reported at least one adverse event. But then with the placebo, 72% of those also reported an adverse event. So it's hard to actually sort of say. I think overall, if you look at the data, tirzepatide does cause more nausea and more diarrhea, not too dissimilar to the GLP-1 agents such as semaglutide and liraglutide. But the discontinuation of study drug due to GI events is relatively low, particularly if you use tirzepatide 5 milligrams but it is still significantly higher compared to placebo. So for a long time, we've sort of had medications that are moderately effective and can significantly improve our odds of achieving clinically significant weight reduction of 5%. But in the last couple of years, we're now starting to see newer agents that are actually allowing us to actually help our patient achieve a much greater change in weight. And I think the future is bright as far as weight management is concerned. So in summary, I think it is important to realize that pharmacotherapy for weight management is a long-term medication. Not all patients will respond to a medication, and cessation of pharmacotherapy in responders will lead to immediate weight regain. And finally, new medications on the horizon will lead to greater weight loss. And thank you for having me.
It was a pleasure. Thank you very, very much. I might just try and share my screen for a moment, Kunal. There's that article that was sent out before the talk from the Australian prescriber, just summarising the medications that are available in Australia and their relative costs. So I'll just remind people of that. So there we go. So can you see that?
Yep.
Yes.
Yep. So yeah, if people want to also refer to this article as well, it'll just kind of summarize or reinforce the things that Carol and Richard were saying about medications. Okay, so thank you very much, Carol. And we're going to move on to our last speaker for the night, and that's Deborah Inman. Deborah is a respiratory and sleep physician at the Canberra Hospital and has been the clinical director of Obesity Management Service since 2022. Her main research interest is in obesity, sleep, and post-bariatric care. And Deborah, like our other presenters tonight, has SCOPE certification. Deborah will be talking about obesity management and metabolic bariatric surgery. Thanks very much, Deborah.
Thanks, Leonie. Can you see those slides there in the proper format?
I can see the slides. Yeah, they're,
Great.
I think you
and
need,
presenter view?
they're a bit small, but we can still see them.
Okay, can you see my notes and things, or are you seeing the proper?
Just seeing the slides.
Just the slide. Okay, good. All right. So thank you for the introduction. Very clearly not a surgeon, but I guess I come at this talk from my background and my context as a public physician through the Canberra Obesity Management Service. But I was tasked with bariatric surgery in 15 minutes. So we'll see how much I get to. But just some brief learning objectives, identifying the indications for when we would consider metabolic bariatric surgery, have an idea of what metabolic bariatric surgery means from the patient's perspective, so you can have a bit of a discussion with your patients about that, and consider situations where metabolic bariatric surgery might not be indicated at that point in time. So brief overview, a one-slide recap from my previous talk, obesity management on a slide, what are the indications, a snapshot of what's going on in Australia, that brief discussion about what life is like for a patient who's had a sleeve gastrectomy, some considerations around indications and referral, and the topic of weight regain. I simply don't have the time to talk about the types and mechanisms of metabolic bariatric surgery and the management, and that in depth, but I'm hopefully we'll get some important learning objectives across. So just to recap in one slide from the previous talk, we discussed the assessment of comorbidities. So both Carol and I talked about assessing a patient who presents with obesity, and I focused on the comorbidities and how the approach to that assessment depends on the time and the context of the patient presentation. We talked about going through comorbidities through the different domains of the medical or metabolic, the psychological, the physical aspects, but also the socioeconomic, monetary context that the patient is in. And combining not just the BMI, but the comorbidity assessment and synthesizing that to try and get an estimate of the risk for the patient in front of us, and how that then informs treatment, and using that Edmonton obesity score of greater than or equal to 2, or meaning the presence of established comorbidity in any one of those domains as a trigger for escalation of treatment, and that obesity management is chronic disease management. Also noting, though, that even in the absence of established comorbidity and not minimizing the potential psychological or psychosocial impact of a person living with a bigger body, there is still excess risk, also mortality associated with obesity. So obesity management on one slide, and just nicely to follow on from my presenters' talks, and particularly Louise and Richard and Carol all made the point that the foundation of obesity management is optimization of lifestyle factors across those pillars of diet, physical activity, sleep, but also mental health and comorbidity identification and management. And they're a baseline even in all the trials of pharmacotherapy. And the same holds true for metabolic bariatric surgery. And that's fundamental to the success, but also the long-term outcome of all these intensive management strategies. And it doesn't stop once someone has bariatric surgery, it continues in the post-surgical frame. So what are the indications for metabolic bariatric surgery? Well, if you ask the surgeons, and if you look at the literature, there are very, very few groups of patients in whom bariatric metabolic surgery doesn't benefit. It's now widely established and has been shown to provide long-term durable weight reduction with comorbidity and mortality benefit. We've got data over 20 years from the Swedish obese subject study. Most recently published guidelines in 22 have been updated from the previous NIH guidelines. You might recall the threshold of a BMI of greater than 40 or a BMI of greater than or equal to 35 with comorbidity, usually diabetes. And that has now been published by the American Society for Metabolic and Bariatric Surgery and the International Federation for Surgery of Obesity and Metabolic Disorders with an update in 2022 and a lowering of that threshold. So now metabolic bariatric surgery is recommended for individuals with a BMI of greater than or equal to 35, regardless of comorbidity burden. Consider it for individuals with class 1 obesity, BMI of 30 and above, who have metabolic disease such as diabetes or fatty liver disease. Acknowledgement of the BMI threshold variation in certain ethnic populations, which I think is important, and that the long-term results of metabolic bariatric surgery are consistently demonstrating safety and efficacy. An extension of the indication to people under the age of 18. It was also interesting to note a large section on metabolic bariatric surgery as an effective treatment for severe obesity in those patients who need other specialty surgery. So in particular, and of relevance to us in the public health setting, of those patients needing joint arthroplasty, so hip and knee, abdominal wall hernia repair, or even organ transplantation, such as kidney transplantation. So what is happening in Australia? The Monash University holds a registry for bariatric surgery and puts out a report annually, and this is the most recent report, sort of snapshot. So despite COVID, over 18,000 primary or first metabolic bariatric surgeries are performed in Australia. And you can see clearly on the right side there that the majority is that of a sleeve gastrectomy, with the historical sort of more gold standard of Roux-en-Y still occurring, and then all the rest. You can also clearly see that more than 95% of these procedures are performed in the private system, and with a very few, so less than 5%, supported in the public system. The average age of patients presenting for the first procedure is in their 4th decade of life, and they're overwhelmingly female as well, sort of nearly 80%. It's generally quite a safe procedure, so adverse events, including unplanned return to theatre, unplanned admission to ICU or readmission to hospital is quite low, 2%. And in this particular cohort, 26 deaths were thought likely related to the procedure, so sepsis, peritonitis, cardiac event or venous thromboembolic disease, which on the denominator gives a mortality of very, very low. You could argue that this is a very selected patient population given the majority are performed in the private setting. But the safety sort of data holds in the published literature for first procedure less than 0.2% is considered a standard mortality. Average total weight loss at 1 year, 29%. And of those patients who had diabetes at the time of procedure, nearly 50% achieved remission at 1 year follow-up. And you might remember from some of the previous talks in terms of comorbidities and interventions, that having your intervention at less than 5 years from diagnosis of diabetes gives you the greatest chance of remission. This, of course, comes with all the caveats of registry data. So not every centre in Australia subscribes to the registry or participates, and there is likely to be some, incomplete data, but I think it gives us a good snapshot. And the report also gives a breakdown of all the states, and so the ACT is very similar in its numbers. So what is having a sleeve gastrectomy like for the patient? And this is, of course, incredibly oversimplified. Not being able to discuss in any detail the psychological impacts, the social impacts, and the physical activity recommendations. But I just thought it was really good to understand the significant reduction in stomach size that occurs with a sleeve gastrectomy. So your stomach size is reduced to approximately a 3/4 cup or 1 cup capacity. The dietary recommendations following a sleeve gastrectomy are to try and have 3 small, appropriate size, sort of 3/4 cup portions spaced evenly across the day. And one might need snacks, particularly early on, to maintain your nutrition requirements, and later on to potentially manage hunger. The time taken to eat is much longer. So a lot of our patients report that they used to be very fast eaters, and that's something that changes significantly after surgery. The need to separate fluid intake from meal intake so that you actually get adequate amounts of both and that you don't stretch the stomach. The profound reduction in appetite and increased in satiety, which occurs almost immediately after bariatric surgery, because you're removing a part of an organ that is not just a sac, but it's also an endocrine and paracrine organ that feeds back to the brain. And so trying to maintain your nutritional requirements in the face of that reduced stomach capacity and a reduction in appetite is really difficult. And I think it's also important to note that satiety is different from feeling full. And a lot of effort is gone to by our dietitians and our psychologists, sort of trying to prepare our patients for not aiming for feeling full, but aiming for feeling satisfied. Protein requirements post-op recommended 60 to 80 grams a day. Now, I'm not a dietitian, so I struggle with macronutrient, grams and things like that. But if you think about one serving size of lean meat, so about a 30-gram piece of chicken, only has about 8 grams of protein. And if you're needing 60 to 80 grams of protein a day, that can be really challenging when you've got such a reduced stomach size. Fiber intake, really important for maintaining regular bowel habits, avoiding constipation. 25 to 30 grams a day is recommended. 2 Weet-Bix has only 3.2 grams. And you could see, 2 Weet-Bix exceeds your stomach capacity already. So often supplements are used to kind of try and bridge that gap. And that can be costly in itself. There's a universal recommendation across a bariatric nutritionist that a bariatric specific multivitamin is recommended. And we come up against this all the time. So it's not a cheap multivitamin. It equates to about $1 a day. And so for some patients, this is a stretch, particularly if they are requiring supplements for protein and or fiber as well. Patients go to a lot of lengths to try and make up the multivitamins with other sort of cheaper brands. And our dietitians will frequently review the options our patients come up with, but almost universally find them lacking. So as our bariatric surgery coordinator tells our patients at the information session, metabolic bariatric surgery is a tool that makes the hard work you do more effective. It doesn't mean you can dispense with the hard work, and it is by no means a cure, and it's important to be prepared for. So considerations for metabolic bariatric surgery are those for a general anaesthetic and also the procedure itself. So considering, is this a revision procedure, is it a primary procedure, and have they had other abdominal surgery? And that might be a discussion with the person that you're referring to. But for instance, severe peritonitis, previous gut resections might just make a laparoscopic procedure unable to be done. Smoking, there's no anaesthetist or surgeon that wouldn't want you to not be a smoker, but I guess the degree to which they're strict on that varies somewhat. The resource setting is really important, and I've referenced the community health pathways there because they do go through some of the options. But despite private health insurance and depending on your level of cover or the fund that you're with, the out-of-pocket costs can still be quite substantial to the patient. And of course, we all know it doesn't cover the outpatient appointments either. I don't know if I'm allowed to say this, but the ACT is a fairly small pool, and some of our patients do seek surgery outside of the ACT where there might be more competition, so the out-of-pocket costs can be less. Some patients do access the superannuation for this surgery, and important to take into account the cost of the recommended allied health support and what may or may not be included with the surgeon. Health Pathways does also mention, that you can discuss the patient themselves funding a private procedure, but I would imagine that would be fraught with, potential problems, particularly if that patient was one of the very unfortunate few who had a complication. The contraindications are not that easy to find, to be honest, but I think generally accepted are at that point in time having a severe untreated major mental illness, uncontrolled or untreated eating disorders, and in particular, like Louise mentioned, current drug and alcohol dependence. So it speaks to all those reasons why a person might not be able to engage with the changes that that surgery would impart on them. But it doesn't mean that having a history of those things precludes them from surgery. It's just, do they have control of that? Is it managed? Do they have a relapse plan? There's all the medical considerations, and that again varies somewhat depending on the centre, the expertise of the team that's looking after the patients. And probably the last one, which I find actually in practice most difficult to assess and to try and establish, is the inability, or potentially in some cases the unwillingness to comply with the nutritional requirements, including that lifelong vitamin supplementation. I think coming back to basics, the first thing we want to do is not do harm. And while we know that bariatric surgery is likely to induce a degree of weight loss, in time, if the person can't comply, it's going to fail. And it might also cause complications for that person in terms of nutritional deficiencies and so forth. Other considerations, nutritional status. So in particular, there's a lot of focus on eating behaviours and patterns. Are there long periods of fasting and large single meals, macronutrient restriction or fussy eating, and potential baseline nutritional deficiencies that have to be investigated and or replaced prior to embarking on a procedure that could potentially make them worse. And I mean, working in public health, you can't go a day without noting the financial considerations for the patient in front of us, be that from a lifestyle perspective all the way through to medication and surgery. We have some limited access to public funded bariatric surgery, but if you look at the indications and the potential benefits, it doesn't meet the demand. And things like that context that the patient's in, so the housing, the food insecurity, are they able to plan and meet those nutritional demands post-operatively, are important to assess. There are a number of subgroups that have been identified as potential contraindications, but as time has gone on, they really have been looked at. Older age is now no longer there's no evidence to support an age limit per se on patients seeking metabolic bariatric surgery generally, but it's thought an assessment of their frailty and comorbidity burden is most important, and there is an increased risk. Similarly, with age under 18, there's now quite good evidence that it produces durable weight loss, improvement in comorbidities that's sustained, and doesn't negatively impact things like growth and puberty. The high risk patient with obesity, so the extremes of BMI above 60 and above 70, and initial sort of data seem to say that these patients were at higher risk and had less safety. But again, as time has gone on, and I guess as surgeons and centres have become more experienced, this has improved. And so while there is noted that there is a higher risk, that there is more comfort in those ranges, and these patients also do benefit. And the medical comorbidity subgroups, again, varied on the centre of expertise. But still, that evaluation by a multidisciplinary team and that support helps to reduce perioperative risk, but I think really importantly, to facilitate the patient's ability to comprehend those lifelong changes, to get the best out of the physical, emotional, financial investment that they're making in their health. And then almost my last slide on weight regain. So weight regain is pretty much universal. In the first decade after metabolic bariatric surgery, the typical weight regain is 5 to 10% of body weight. And if a patient is not prepared for a degree of that, that can be really demoralizing. It occurs regardless of the procedure, so be it lap band, sleeve gastrectomy, or even Roux-en-Y, but the results or the outcome varies across the procedures. Generally, peak weight loss is thought to occur by about 2 years, and then there's a slight increase and it evens out by about 8 to 10 years. But we've seen many patients at the OMS with historical sleeve gastrectomies, even Roux-en-Y, who've had relapse of their class 3 obesity, so BMIs more than 40. The other sort of things that I haven't had a chance to go into detail, and I've defined a bit variably in the literature, but inadequate weight loss after metabolic bariatric surgery, early weight plateau and regain, and excessive regain after bariatric surgery. And this probably relates mostly to stretch of the stomach, and again goes back to sort of a lapse in dietary habits, so particular portion size, grazing, so keeping up with or adding excess calories while not trying to while maintaining that hunger decrease or the satiety. Comfort and stress and non-hungry eating, and that often does involve the discretionary convenience high calorie but low nutrient foods and alcohol. And underlying all of this is our obesity as a chronic disease. And we all know that chronic diseases tend to progress. And so there's probably an element of this as well that exists in the phenomenon of weight regain after surgery. So it's not a cure. So in summary, metabolic bariatric surgery is currently the most effective and durable treatment option for obesity. And while we might have pharmacotherapy that's catching up, I think the big caveats of the duration of therapy and the cost to the patient, which is probably one of our biggest barriers, are what still, for me, sets it below metabolic bariatric surgery as a long-term option. It is safe, but it is not the cure. And the patient context and timing is important. So is it the right time for that patient? It does involve significant change to a person's life, and they need to be prepared for that. Firstly, so we don't do them harm, but also so they get the most and prolonged benefit out of it. And the resource considerations are very real, given that the majority of this occurs in the private setting. And again, obesity management is chronic disease management, and weight regain is something that we have to have a plan for. So again, surgery is the tool that makes the hard work you do more effective. It doesn't mean you can dispense with the hard work. And my sincere apologies, but I had to sneak in this meme because I really love it. Okay.
Thank you, Deborah. That was great. A nice meme as well. So now we're going to move on to looking at the pre-event questions. So I'll just share my screen. There we go. Okay, can you see that?
Yep.
Yep. Great. Okay, we'll start off with Richard. So Richard, if you want to start addressing your questions, and then we'll move on to Carol, and then Deborah, and then Louise.
Okay, so thank you, Leonie. So the first question was, should anti-obesity drugs usually only be prescribed to those that have an appropriate, I'll read it properly. Anti-obesity drugs should usually only be prescribed in those with an appropriate lifestyle because, and it was nice to see that most people actually did choose the same answer as me. So there were a handful that thought that because obesity is a lifestyle disease, we need to make people demonstrate that they're making an effort, which I think is incorrect. We're trying to treat the chronic disease of obesity, and we need the lifestyle in order for it to work rather than to demonstrate their work ethic. And it's not true that weight loss drugs won't result in weight loss without appropriate lifestyle. It's that you won't get a durable response. And it's also not correct that weight loss have more potential adverse events than most other drugs we prescribe, although admittedly it depends which one you're talking about. So for something like phentermine or topiramate, that possibly is true, but for the GLP-1s, I don't think it is. So question 2 was a 60-year-old man with a history of depression, a corneal transplant, 3 uric acid stones, hypertension and diabetes, who had stage 1 obesity. He was taking an SNRI, venlafaxine, irbesartan, amlodipine and metformin, and had good diabetic control with a stable body weight for 10 years, having gained weight earlier when he was prescribed amitriptyline. He has a good lifestyle. So you tell him, now can you just scroll down a little more?
Sorry. Yeah.
So because he's had a corneal transplant, we cannot use topiramate. So in fact, an ophthalmologist did tell a patient of mine that when I wanted to use topiramate. I don't necessarily agree because they are completely unrelated, but I wouldn't say it's wrong, given that an ophthalmologist said it was right. Topiramate will increase his risk of kidney stones, so we can't use it. Well, it will increase the risk of kidney stones, and about a quarter of people pick that as an answer, but it's not likely to increase the risk of uric acid stones, which are mostly due to urine pH, and it's not going to have a dramatic effect on urine pH. Phentermine will make his blood pressure harder to control, but this is probably manageable. So quite a few people like that. I don't like it mainly because he's taking venlafaxine. So while the blood pressure issue may be manageable, I think it would be quite risky to give it with an SNRI because of the risk of overstimulation with the noradrenergic side effects and serotonergic side effects. So the correct answer is that orlistat won't adversely impact the hypertension and has low risk of exacerbating his other comorbidities. It won't increase the risk of uric acid stones. I guess it was a bit of a nasty question though. So certainly it would increase the risk of calcium-containing stones. The next question is, a 30-year-old woman says she's been gaining 2 kilos of weight per year, current BMI just under 27, on no medications, no comorbidities apart from intermittent panic attacks managed with cognitive behavioral therapy. She does quite a lot of exercise. She has mild hypertension, and she comes and asks you for a weight loss medication. And so almost everybody picked option B. Good that she's recognized weight gain as an issue. A drug may be useful in the future, but probably won't reverse the increasing weight that she's currently experiencing. So look at lifestyle first. And quite a number said that you'd like to have an ambulatory blood pressure and urine albumin creatinine ratio with a view to starting metoprolol, which maybe would help with the panic attacks and the hypertension. So metoprolol is the beta blocker that has the best evidence for causing weight gain. So when she comes asking for weight loss, it wouldn't, I mean, they all to some degree cause weight gain, but metoprolol from the Gemini study is known definitively to cause weight gain. So question 4, a 50-year-old woman has been taking topiramate for 2 years without apparent adverse effects. Her weight's come down by 10 kilos to 90 kilos and then's been stable for 18 months. You'd forgotten to tell her when you prescribed it that it could cause kidney stones, but she read up on it and is keen to now come off the drug. So what do you tell her? And then if you just scroll down to the, yep, thank you. So we have quite a mix here. Not very many people said that it's a great idea to stop the medication because it isn't working. So I'm pleased because she's actually sustained a very good weight loss. So I wouldn't say that that's the correct answer. Quite a number, just over a quarter, thought that because her weight's been stable, there's a relatively low risk of weight regain if she ceases. And I disagree with that too. She is very likely to regain the weight and begin to regain the weight as soon as you stop. And she'll probably regain all the weight, so C is not correct. And that leaves us with the final answer that she probably will regain all of the weight lost if you stop that medication, unless, of course, you replace it with something else.
Okay, thanks, Richard. Okay, now, Carol, you're in the hot seat.
Can you hear me? Okay.
Yeah.
So I only have 2 questions for this particular quiz. And so question 5 with regard to anti-obesity medications, which one of the following is true? So I think most of you have got it right that anti-obesity medications, in fact, any of the ones that are on the market at the moment, significantly increase the odds of being able to achieve a clinically significant weight loss. Now, in one of the slides that I have shown you, the vast majority of the anti-obesity medications that are on the market, in fact, all of them has not been able to actually show us that the majority actually will lose the weight of more than 10%. That's in one of the slides. Lifestyle intervention, is not important when using anti-obesity medications. I'm pleased to see that no one selected this option. So all of you have been paying attention for the previous two webinars. So that's really great. And the final one says anti-obesity medication should be ceased once the patient has achieved the goal weight. And as we just discussed before, that if you do that, then the weight gain weight regain will be immediate. So that's generally speaking not a good idea. So most of you have it right. So that's really great to see. Next question, question 6. So question 6 is talking about GLP-1 agonists, and the options are GLP-1 agonists reduce hunger and increases satiety, and that's definitely correct. That's how GLP-1 agents work. Now, GLP-1, the next sort of response is GLP-1 agonists are contraindicated in patients with previous pancreatitis. Now, there are some reports of a GLP-1 agonists can be associated with pancreatitis, but if you actually look at the prescribers' information, the only contraindications for prescribing GLP-1s is actually allergy to one of the components of the drug or its excipients, and also personal or family history of a thyroid medullary carcinoma. So there's actually no mention in the prescriber's information about the previous pancreatitis. Then the response number 3, and all of you got it right, liraglutide is not more effective than semaglutide. In fact, the converse is true. And then the option number 4, that liraglutide should be ceased if a clinically significant weight loss has not been achieved after 3 months at 3 milligrams per day. And that's generally, when this happens, then the patient is usually considered as a non-responder, and therefore we should stop the medication and try something else. So in fact, 71% of you got it right, and the correct answers A and D.
Hey, thank you. Now, Deborah.
Thanks. So metabolic bariatric surgery is indicated for BMI of 27.5 with hypertension. Well, potentially if you had an ethnic background that puts you at risk, you would fall into that category, but I didn't specify that. And same with the second. BMI of greater than or equal to 30 with type 2 diabetes. So yes, class 1 obesity now with a metabolic complication would be considered an indication for discussing or considering bariatric surgery as a treatment option. And BMI of above equal to 40, of course, but not only of type 2 diabetes. That actually holds alone as a BMI indication. And then C and D, you could probably argue they would both be correct, but I put that word only there as being tricky. Sorry. Go down. A contraindication to metabolic bariatric surgery is poorly controlled type 2 diabetes on high doses of insulin. So I wouldn't consider this a contraindication per se, but ideally better glycemic control would improve perioperative outcomes or postoperative outcomes. So it wouldn't pose a contraindication, but it would be something to work on prior to surgery. A person with stable schizophrenia, so no admissions, maintained on antipsychotic therapy, I don't think is a contraindication. And age above 65 years. So depending on your resource setting, again, not a contraindication being above the age of 65, there's still clear benefit for this patient subset, but perhaps a slightly increased risk depending on their frailty and comorbidity assessment. Child pure A cirrhosis is not considered a contraindication, and even child pure C now, although this would be my preferred answer for this question. So I did the questions before I did the final slides, but I think this depends on your area of expertise and the multidisciplinary team you've got looking after the patient. So there's even descriptions of surgery being performed in those being listed for liver transplant, which I found amazing, but I would pick that answer. And then in which of the following scenarios, the last question, is referral for bariatric surgery appropriate? So scenario 1, 52-year-old woman, class 3 obesity with a BMI of 42, hypertension, asthma and osteoarthritis, a relevant comorbidity, recently been found to have lymphadenopathy and is awaiting lymph node biopsy. She's asked you for your advice on metabolic bariatric surgery. And I think, again, this is a case of at the point in time in the patient context. So while she clearly fulfills criteria for, being appropriate potentially for bariatric surgery, she has the potential for an active cancer diagnosis, and undergoing or a need to undergo chemotherapy would be a contraindication. 27-year-old woman, class 3 obesity with a BMI of 40 and polycystic ovarian syndrome, hoping to start a family in the next 6 to 12 months. And again, it's that context of the patient. So metabolic bariatric surgery, pregnancy is advised strongly against in the 12 to 18 months following surgery because of the potential negative impact on a growing fetus. And actually significant weight loss by any means can trigger fertility. So it's really important that she's on effective contraception, both for the health of the child, but also so that she doesn't negate the potential effects of the surgery and has early relapse. Number 3, which was the option the majority of you chose, a 35-year-old man has been gaining weight. He has a BMI of 46. He has hypertension, obstructive sleep apnea and gout. Weight has increased by 25 kilograms in the last 18 months. He tells you that bariatric surgery is the only option that will reverse his weight gain and nothing else has worked. And I think this is a gentleman, while on the first line he would fulfill the baseline criteria for metabolic bariatric surgery. Sorry, on cue, I have my 3-year-old. The rapid weight gain in the preceding few months or 18 months is a real red flag, and it suggests to me that he needs a review of why he would be gaining weight, because it's likely to be maladaptive eating behaviors, untreated potentially sleep apnea might be driving a lot of his obesity. So he needs that addressed before he would gain the best from metabolic bariatric surgery. So it's not a rescue therapy. And then the last option is the one that I would choose. So 43-year-old BMI of 39, diagnosed with diabetes in the last 6 months. So you've got a really good shot at getting him remission with clinically significant weight reduction. He's on metformin, has a history of depression, but I've not indicated that it's poorly controlled, although that's something you'd assess when you saw him. He has initiated some diet and lifestyle changes with the help of a dietitian and your advice, and he's managed to lose 4.5% of total body weight. So I think, just in very brief, he represents a candidate who would potentially do quite well with the impact of metabolic bariatric surgery on his life. And technically, all of the above have some criteria, but at that point in time, only one really fulfills criteria, I think.
Okay, thank you. And nice to see your 3-year-old as well.
Sorry.
Okay, so now, Louise, you've got the last kind of gig. So over to you.
Okay, so the question 10, or my first question was, what is an appropriate obesity management goal setting strategy? So the first option was identify a specific target weight in kilograms and a time frame in which to achieve the weight loss. So as I mentioned earlier, having too specific a goal, so a goal weight isn't what we really aim for, and also having those strict time frames is really setting up a person to potentially fail and to be reduce their motivation if they don't achieve those goals to start with. So A was not right. B was focus on preventing further weight gain and promoting weight stability. And C was aim for 5% of total body weight loss, which is what we describe as clinically significant weight loss. So the right answer was B and C. Again, D was really sort of referring to something that's just really too strict to maintain long term. So moving on to question 2, thanks, Leonie. If a person with obesity is experiencing depressive and anxiety symptoms, so A was advise them that weight loss will improve their overall mental health. That could technically be the case, but you know, I think it's really important to explore those symptoms and see whether or not there's actually an undiagnosed depressive or anxiety disorder there. And weight loss is not necessarily a magic solution to some of the mental health challenges that people face. So B, the option was prioritize weight loss and then reassess their mental health at a later date. So no one chose that, which is good. No one chose C, which was considering a mental illness and prescribing a TCA. It's not to say that a TCA isn't warranted in some mental disorders, such as a really difficult to treat depression, for example. But again, it's probably not the first line option that you would go to because of its weight promoting properties and other side effects as well. But essentially the right answer was D, which is assess for an undiagnosed depressive or anxiety disorder and consider prescribing an SSRI or referring to a psychologist or both. And most people got that one right, which was good to see. And then the final question, management of comorbid obesity and binge eating disorder includes A was restricting food intake to reduce the likelihood and frequency of binge eating episodes. That wasn't correct. B, considering prescribing lisdexamfetamine or topiramate for weight loss purposes. So this is a bit of a trick question. Those medications both have a potential role in treating binge eating disorder, but not from the perspective of losing weight. So that's something to keep in mind. And that's why C was the right answer. So all of the options in C are something that you could consider in treating binge eating disorder in conjunction with psychological therapy. So the medication's only going to do so much. And D was also, so it was C and D, which was the right answer. So again, that psychological input is really important. Thank you.
Thank you very much. So our presenters have been kind of quick off the mark and have been answering your question and answers as they've been typed into the Q&A boxes. The presentations have been going. So we've only really got one outstanding non-answered question. And I think this will be one for Richard or Carol. And the question is, if the patient maintains the reduced calorie intake and exercise regimes, will they still regain weight once the anti-obesity medications are ceased?
Yes, they will. Yeah. So if they've lost weight through, so if they've originally lost weight through lifestyle and they've lost a certain number of kilos and they maintain that lifestyle, and then they start an anti-obesity medication and lose more weight, and then they stop the obesity medication, they would return to the weight they were, generally speaking, before they started the weight loss medication. So if you've had two interventions, so if you've had a change in lifestyle, you would expect to maintain that weight loss, but you won't maintain any of the added weight loss from the obesity medication.
Right. So
agree with that, Carol?
Yes, I guess that's what the literature is showing, isn't it? I mean, for most of the studies, what they did is they actually implement a lifestyle intervention. They put the patient on the medication, but when you actually, remove the medication, the weight regain occurs, even though, in theory, the lifestyle intervention is still in place. But I guess the thing is, if you look at the literature, if people were able to lose weight and say maintain a much lower body weight for 5 years, there's actually nothing in the literature to say, wait, what actually will happen when you stop the anti-obesity medications? But, my feeling would be, if you are on the anti-obesity medication and that has proven to be effective, you're probably going to take it for quite some years. I mean, we know the physiological adaptation that occurs after weight loss with increased hunger hormone and reduced satiety hormone levels actually persist beyond 12 months and can be seen quite some time later. So I think, you probably be looking at treating with anti-obesity medications for quite some years, if not forever.
Thank you. That's a bit of a depressing thought given their costs. So I've just had a
But then by the same token, you know, do you tell your patient that, look, you know, if your blood pressure is okay for the next 3 years, we'll stop the blood pressure tablets?
Yeah, well, they're not on the PBS, so the blood pressure medication's a little bit cheaper.
Well,
So,
but then perhaps it's not a problem with the medication, it's a problem with the PBS, isn't it?
yeah. So my question is, are you aware of any of the medications going for PBS listing?
I think in the ideal world that they love to, but I think the PBS is quite concerned about the cost that's likely, you know, to be borne by the taxpayers, particularly when you're looking at something like Saxenda, which costs about $384 a month or so. And conceivably, if it's on the PBS, there's going to be a lot of patients who will be eligible for treatment.
Yeah. I just had one question. So, Louise, would you recommend that patients on antipsychotics with weight gain consider going on metformin, or does that help at all with the weight gain?
That's a really good question. Look, I don't think it helps, in my experience, with preventing weight gain so much, but it does have the benefits of preventing progression to type 2 diabetes, or it helps with their metabolic profile. In terms of using some of the other medications that Carol spoke of, or even the ones Richard mentioned too, the ones that potentially have a risk to precipitate or exacerbate psychosis or mood disturbance, it's that risk-benefit ratio again. But interestingly, there are some trials going on in Queensland at the moment, looking at a schizophrenia population using the semaglutide. And there's also some evidence from Canada that shows that people are being treated effectively for a schizophrenia illness and also weight loss with one of these new types of anti-obesity medications.
Right, thank you. Yep.
Can I ask a question, Leonie?
Yes.
I guess of Richard and Carol and Louise with their experience. But keeping in mind the cost of our medications, and I admit freely that topiramate is often the medication that I come to a shared decision-making process to commence with a patient as a trial to see if they're a treatment responder based on cost alone. Would you consider a history of a single renal calculus, I'm sorry, I don't know what kind, a contraindication?
Richard,
I realized that. I was trying to send a citation for the Gemini study. I think it does depend what type of kidney stone it is, because I mean, the risk of recurrence of kidney stones, you know, over the next 5 years is quite high. And if you're thinking of a drug that is going to, you know, definitively increase the risk of a calcium containing stone, which are by far the most common type of stone, then I would be hesitant. I mean, you have to balance the risks and benefits, but I would be hesitant to use it in someone with a history of renal stone, unless the renal stone that they had was a uric acid stone, which is about 10% of stones, which I wouldn't expect it to increase the risk of.
And I've got one question for Carol. So compounded low-dose naltrexone, I think, is not prohibitively expensive. Is there anything to say that naltrexone on its own at, you know, a 6 or 8 milligram dose is effective for weight loss?
Can you hear me?
Yep.
Yeah, I have not actually seen any sort of trial where they use the naltrexone alone. So I guess the answer is I don't know. I don't know whether any of the other presenters have seen any trials using naltrexone alone.
Oh, well.
Yeah. I mean, one of the reasons we use topiramate alone instead of phentermine topiramate is that topiramate has actually been shown to actually reduce weight, and there's actually randomized trial data, and we know that there is actually a weight effect, but I don't think I've seen any papers with using naltrexone alone.
Yeah. Okay, interesting. So I think we'll wind it up there. I just wanted to say thank you very, very much on behalf of Capital Health Network to all our presenters. They've been wonderful to work with. They've put in a lot of time and an effort into these presentations, and they've been really informative and of really high quality. So thank you again very much for all your efforts over the last few months. We also have put out on the evaluation survey, if our presenters, because they're such lovely people, would be open to presenting more webinars on obesity. So if you're interested in that, please put that on the evaluation survey and just list the topics that you'd like to be covered, and we can have a look at it and present it to them and see if they're able to provide information on that. So thank you again to all four presenters. It's been a real pleasure working with you. And just to reiterate, if you want Capital Health Network to upload your CPD, please send us your evaluation surveys with your RACGP number by the 15th of May. Otherwise, you're very welcome to upload them. And there's also those 30 extra minutes for CPD if you do the pre-reading and the questions. And we're going to send out to you the presentation slides and also put this webinar on our Capital Health Network YouTube page. Thank you very much again, and good night.